Still, we have the session of comments and questions. So please welcome if you have any question. Welcome. Thank you your lecture. It was amazing, and we benefit a lot about your lecture. The question I would like to ask you is how common, because you put them up in Somalia, so how common in Somalia, because we haven't seen a lot of patients and this kind of disease. So I would like to ask you how common and how common it spread. Is it spread in contacts, or is there any ways that it's spread, this mycetoma? Thank you very much.
Because there is no recent publication of mycetoma from Somalia. And Ahmed is working on that, hopefully going to come with a review article on the cases of mycetoma reported in the past in Somalia. And that will tell us about how frequent the problem was. We need to go to the literature and to look into the last 50 years, 70 years, and then you can dig on the cases, and then you can come with some statistics about the cases of mycetoma in Somalia. The most important is it is here, available. In Sudan, we have 2-3 cases coming from Somalia. Some of them were students studying in Sudan, and they present with mycetoma in the center there at that site. So it is common, it is there, but we are not looking. We are not sure how much cases are available there, because these patients, they never come to you. You have to go to them. You have to go to the villages, and you have to search for these patients. These patients are from the low socio-economic status, and the problem is painless, and they are not bothering themselves by this. So we need to go and find these patients at the level of the village, and then we can tell about the incidence of mycetoma in Somalia. But you have Mycetoma somaliensis. This is one of the important causes of the bacterial type of mycetoma. That means it is there, even given the name of Somalia. So it is important to look for this patient.
waxaa xusid mudan Soomaaliya in mycetoma ay joogto horta kuma jiro, laakiin waxaan weli caddayn inta ay tahay. Doctorku wuxuu codsaday, prof dhow beri uu joogo, wuxuu codsaday in aan study samayno, gaar ahaan review article ka bilowno maxaa Soomaaliya hore looga sameeyey, dabeetana aan halkaa ka ambaqaadno. Waxaa jirta nooca bakteeriyada ah, nooc ka mid ah oo magaca Soomaaliya la siiyey 70-aadkii, Streptomyces somaliensis baa lahaa, mycetomaday ka mid tahay. Marka laynkaas ay noogu jirtaa, Streptomyces somaliensis waa mid ka mid ah mycetomada oo caan dunida ka ah, markeed ugu horeeyana Soomaaliya laga helay. taa laftigeeda in la sameeyo wax la yiraahdo sequencing oo phylogenetic tree-geeda la ogaado cidda ay tahay iyo cidda ay u dhowdahay. Yani phylogenetic tree-ga marka la sameeyo waxaa la helaa sidii sawirka halka ku arkaysay, waa loo abtiriyaa organisms, waa loo abtiriyaa. Marka yay abka ab yay isku aaba yihiin, macnaha yay isku meel ka soo farcameen, yay isu dhow yihiin, noocaas la sameeyaa. Marka insha Allah hopefully waa rajaynaa dhakhaatiirta iyo dadka medicalka halka jooga in istadiyada laga qayb qaato. waxaan kaloo aad u rajaynaynaa caseska inaan aragno, waxaan isku dayaynaa insha Allah within 3 months inaan dhigno wax la yiraahdo laboratory diagnosis inaan sameeyno oo basic ah. Marka dhakhaatiirta case-ka noocan oo kale markay idin yimaadaan inaan wargelisaan insha Allah haddii Ilaahay idmo, oo aad noo sheegtaan in caseska noocaas ah haysaan, dabeetana aan isku dayno sida u caawin karno inaan u caawino insha Allah haddii Ilaahay idmo.
I would like to thank Professor Ahmed Fahal for his very good and very nice presentation about the mycetoma. I have one question, but I want to comment the question of my brother who was Dr. Ahmed, who asked how common is the mycetoma in Somalia. I think it is I can't answer as Professor said because we don't have statistics. But what we know that we see the patients. For the last year, I have 2 cases who ended up with amputation because they have a massive and like wet gangrene. And it's very common. And as Dr. Ahmed said, there is one germ which is carrying our name. That means it's here in Somalia, and we see the patients. We see a lot of patients who refuse amputation, as Professor said, because it's a stigma. So it's common, but it's neglected. And even it has a Somali name, we call it hule. I don't know, have you ever heard hule? Yeah, we call it hule in Somali, so that means, yes, we call it horre, we call it, so it's common, that means it's common, because it has a Somali name. So, Prof, my question is, I want to ask the duration of treatment after resecting the mycetoma. That's post-surgery.
For the bacterial type, as I mentioned, you give combination of antibiotics, augmentin, 1 gram per day, and amikacin sulfate, 1.5 gram per day in 2 divided doses until the patient is cured. Given in combination with co-trimixazole, Septrin. It may take 6 months, it may take 2 years, it may take 3 years, depending on how massive the problem is and how resistant the drug, resistant the organism for the drug at this site. For the fungal type, we start with antifungal drugs, itraconazole, at least for 6 months. During this time, we are not looking for cure. We are looking for encapsulating the lesion by the fibrous tissue. So Cladribine can remove it completely under aseptic condition and can remove it under a tourniquet, trying to remove as much as possible from this organism and dead tissue at this site. And post-operative, we have to go at least for another 6 months to avoid recurrence in this patient. Sometimes you may have more 1 year, 2 years, 3 years. Sometimes the patient may not respond to treatment. So you have to be patient with the patient and try to give it the treatment as much as possible. The important thing during treatment, you have to measure the liver enzymes and the full blood count and the renal function to make sure there is no toxic effect of the drugs in the kidneys and the liver and the blood and this.
Yes. This disease, I think this disease is not common in Somalia. I haven't never seen a case with a stomy or meeting that clinical symptoms. But Dr. Abdel said I have seen some cases. Maybe I haven't been in the hospitals more. But one more question is that I'm a reference specialist. As you have been working on this disease for a long time, have you established a surveillance system in Sudan that captures the cases? And is there any standardized case definition for that disease? That's another question.
Yeah, we did a lot of surveys. We did a lot of surveys in the Mycetoma endemic area, especially Eastern Sinnar area, and we looked into these villages. We did house-to-house survey. And in each house, you look for any evidence of mycetoma among the household members. And then if it is there, we take him to one of the center for diagnosis to be confirmed at this site. We published 3 papers on the surveillance system we're using there at the Mycetoma Center at this site. We are now having this holistic approach for mycetoma management. It is the patient, the community, the environment, and everybody is seeing at the same time at this site. Your work is much appreciated to work together, to look into the environment, to look into the surveillance system, and how to prevent it, and how to see more of the dental cases at this site. You're working for WHO?
Yes, I work for WHO.
Why WHO is not using? Why WHO is not including mycetoma in this list in Somalia? You have to talk to the director to include mycetoma in the neglected tropical disease list at the WHO in Somalia.
Fahal, for this interesting topic. And I have to admit that I haven't been through mycetoma since the my early days in college. So I haven't even been through these ugly cases. It's just like cancer, and it should be considered as a cancer. It's destructive. There is no cure. So my question is, why not to concentrate the researches on primary care and prevention rather than waiting for these patients coming late? I don't know whether any research is done in primary care. Primary care and prevention.
Yeah, yes. Prevention is difficult because still we have a lack of information about many of the epidemiological characteristics of the problem. But we are doing a lot of primary care activities. We go to the villages, we do surveys, house to house, health education, talking to the people, trying to improve the environment. In one village, we built about 72 new animal cage outside the village, trying to reduce the contact between the animals and between the human being at this site. So we did a lot of primary health care activities while having two satellite center. The center in one of the villages where mycetoma is endemic, we are working there. In one of the villages, we have this center. We did about 1,000 operations free of charge for these patients in the village, trying to prevent them from coming to the center in Khartoum for care and expensive transportation, accommodation, and this and this. We did more than 1,500 ultrasound exams free of charge in these villages. So we are working now at the level of the village, at the level of the primary health care, trying to reduce the burden of the mycetoma at that area. There's a lot of work to be done for mycetoma patients. By the way, you have a lot of patients with female with mycetoma. One of them, she had a very massive mycetoma of the foot. She had an amputation. She had a spread in the inguinal region to the vulva and to the perineum and to the anterior abdominal wall. And she was cured. And she got pregnant. And she had a cesarean section.
She's lucky.
Yeah. Yes. Another patient came with mycetoma of the vulva, with a bad circumcision, with a vulval mycetoma. She had an acute retention of urine because the bladder was obstructed by the mass. And she had a urethral stricture, bladder dilated, by bilateral hydroureters, and she was in a very miserable situation.
Some comments, and also I have some questions. Specifically, this topic is very interesting outside. This topic, I hope so. I'm a orthopedics surgeon, so I saw almost 3 cases, 4 cases in my life. I'm also, for that, very interesting. So, in Somalia, yes. This Maduro foot is common in Somalia, especially around the capital of Somalia, the farmer sides. But Puntland and Somaliland side is somehow is dry area. So I have some comments. First of all, I will thank Dr. Ahmed Hasan for this very interesting seminars, and he will update us for the mycetoma issues. This also is a very challenging management, whatever. It is a multiple disciplines. Example, it needs a dermatological evaluation, it needs an internal medicine follow-up, it needs also rehabilitation center like Dr. Yahya, what he's telling us, and also it needs final for general surgery evaluation and final orthopedic because affected the bones. So I have some questions. My first question is there is any specific time to reach the mycetoma to the bone for your experience? That's the number one question. The other thing, this disease is common for a low socioeconomic community. And the investigation modalities, maybe the patient needs for X-ray, ultrasound, CT scan, and also MRI. And all of those image modalities is very interesting and it's cost. So that's one is how can the article is mentioned for that modality investigations. The other thing is antibiotics and also antifungal drugs. The article is sometimes they mention us, is one complication of the mycetoma, because the disease maybe it stay long period of time, years and years and years like this. So it's another. So is there any advice for that to minimize that one? Finally, any advice for such challenges, because you have experienced a long period of time. So any advice, especially in Somalia and these areas, to advise us, because all our doctors is somehow very junior doctors, so we need to advise if you have some tricks and tactics such like this. Thanks, Doctor.
Again, the spread of the mycetoma along the facial tissue, facial plane to the bone, it depends on the organism. The bacterial type is spread fast along the facial planes to affect the bones. And in the bacterial type, you have the Actinomadura pelletirii. That is the bacteria which have a red grains. Very aggressive, can affect the bone as stage. But the good thing, it responds very well to treatment. Again, the spread, it depends on a lot of factors. Some of the patients, they come with a massive lesion in a very short duration, and some of them, they come with a very small lesion for years and years. Very much localized, painless. You do the surgery, and it was fine as a surgical surprise. So again, we don't know why some of the patients have the disease very much localized for a long period of time without spread. And why some of the patients on the other side, they have a small, short duration with a massive disease. So we need to look into the organism itself. It may be a very aggressive type of organism, it may be the immune system of the patient, maybe other factors can lead to these things at this side. So this is for the spread of the mycetoma along the facial plane to the bone. Other time, difficult. Difficult. Even in experimental animal, this was not studied, because very difficult to say 5 months, 3 months, you have the bone affection at this side. Sometimes you see the bone is normal on the X-ray, but in fact when you do the MRI, it is massive mycetoma there. So again, it depends on the tool you are using to see if the bone involved or not. There are many tools to have the spread of the mycetoma, MRI, CT scan, and ultrasound. But the ultrasound, it is a more feasible and easy one to use, especially in our countries. A mobile ultrasound, you can scan the whole village and you can get the diagnosis of mycetoma. It has a very clear characteristic features, and you can differentiate between the mycetoma and non-mycetoma lesion, and between the bacterial and the fungal type of mycetoma by ultrasound. So people are encouraged to use ultrasound for the diagnosis. X-rays will show you the bone changes at a later stage. The MRI, it is very useful for the extension of the problem, but expensive, not available in many centers where mycetoma is endemic. So let us think about the ultrasound, a mobile machine, tell us about the problem and how can we diagnose the problem of mycetoma at this site. The third question, all these are challenges. Diagnosis, the treatment, prevention, early case detection, all these are, and the ignorance of the international community. In ignorance of our colleagues. They don't want to deal with mycetoma patients. These are dirty patients, they are infected, they are difficult, they are very poor, they are not paying in the private, and they are not taking him to the private theater, okay? And they can't, and this is the problem. That is why they are neglected patients at this site. Our challenge, it is to educate ourselves, our community, medical and health community, about the care of the mycetoma patient. Remember, this is a human being. They may be affected by the problem for life. The problem is there, it is painless, gradually increasing in size, leading to deformities, stigma. You had an amputation, and you had another stigma. They lose their work, they lose their education. Female cannot get pregnant. cannot get married. If they can get married, they cannot get pregnant because they cannot take the drug during pregnancy. They cannot feed the baby after that because of the drugs at this site. So there's a lot of challenges. Let us think about these patients as a human being, about the problems of these patients, and about the ignorance they are facing these patients. I remember I was speaking to one of the ministers in Sudan about the mycetoma and ignorance. He said, unless one of the ministers had mycetoma, nobody will look to take care of this. So this is one of the problems. They are neglected because by the community and by the people and by this.
But Mr. Fahal, after all these papers and researches, there are still many questions not answered.
Absolutely. Because we are working single hand. Very few people around the globe working on mycetoma. Very few centers dealing with these mycetoma patients. Okay? We came now with a new drug, which is a very good breakthrough in the management of mycetoma patients. Now we are working 4 or 5 international universities to have a diagnostic test which can be easy to use. And hopefully in the future we can have more answers for these questions. All these paper has just led the way to understand the mycetoma properly.
I'm Dr. Jamal Aw Saleh, consultant physiatrist. This is the name of our specialty. I will not talk more because Dr. Yahya already talked about that. But throughout the presentation of Mr. Al-Fahal, he talked about the high recurrency of this disease. My question for Mr. Al-Fahal as a researcher in this field, have they did any measurement throughout the research to reduce the recurrency percentage? And if they did, what is the procedure for that? I'm thankful for it.
Mycetoma is a benign inflammatory disease, okay, but has a malignant behavior, just like the cancer. Local destruction of the tissues, recurrence after proper treatment, and spread. So these are the 3 important features of any malignant disease, unless it is a localized malignant disease. So the same behavior it is with mycetoma patient. You need to have a very good surgical intervention. You need to have a very good surgical procedures. Operation should be done with somebody who has a good experience in mycetoma surgery, under good condition, under tourniquet, light, and patient to remove all the dead tissue, all the infected tissue, and the grains in that area. Leave the wound open for post-operative dressing with antiseptic solutions, trying to kill or to remove all the unremoved grains, hyphae, or organism. Okay? So number 1, it is the technique. Secondly, the early presentation. The important thing is still you have to look into the biology of the disease. Why cancer recur? It's the same as mycetoma. Why mycetoma recur? This is one of the characteristics of the organism. Probably we are dealing with hyphae. You cannot see it during surgery. There are believed that the organisms are taken by the lymphocytes and they move away from the area and they can spread to lead the infection at this site. So this is one of the beliefs that the cause of the recurrence, that is the organisms are taken by the lymphocytes and they spread to the renal lymph node or the other places, and that may be one of the explanations. But remember, we have the same malignant behavior.
Yes, it is spread. So
Yes.
the
But
question, is it contagious?
no, it is not zoonotic. It is
These
not.
grains does not.
No. If you have the grain accidentally during surgery, you're not going to be infected by mycetoma because they need a special environment. They need a special system in the body immune responses, and this and this and this.
But you have to have a break in the skin, right?
Even if you have a break in the skin during surgery, and you have the implanted of the grains, it will not grow. It is the organism. The grain, it is encapsulated organism with these things. Yeah, hopefully, yes. We don't know, طبعا. It depends, as I mentioned, with a lot of factors. Where is it? The organism, the susceptibility, the response to treatment, the immune status, the genetic background. All these are factors that determine the incidence of recurrence of this patient. Sorry? Absolutely. Can be an important reason.